Our next speaker is Paul McBeth. It's my pleasure to introduce Paul. Wherever he is, there he is. Paul's one of our partners in Calgary. He's a really interesting guy. He was an engineer before he went into medicine and spent at least a couple of years working in a robotics laboratory and something called NeuroArm, which is essentially an autonomous neurosurgical robot that's now entering into production. It's really pushed not only space flight and medicine forward, but a bunch of other things. So Paul looks at the world a little differently than certainly a lot of us. And I mean that as an extensive, an extreme compliment. So Paul's going to talk to us today about coagulopathy and trauma, and we asked him to boil it down and give us the nuts and bolts for, again, those of us like Sandro that aren't as bright as these guys.
Thank you, Dr. Ball, and thank you for the opportunity to present today. I'm going to be talking about coagulation and trauma, which is really an interesting topic that's grown a lot in the last several years, and talk about a little bit about the future of coagulation. So the objectives of this talk is to give you a little bit about the historical perspectives of resuscitation and trauma and the associated coagulopathy, to review our current understanding of the pathophysiology of trauma-induced coagulopathy, and lastly, to give you an understanding of some of the concepts and clinical applications regarding thromboelastography and how it's being used now in the management of and identification of patients with coagulopathy. So as we all know, trauma is one of the leading causes of death and disability worldwide, with massive hemorrhage accounting for 30 to 40% of trauma mortality. And nearly 50% of these deaths occur within the first 24 hours of a patient's arrival to hospital. About a third of these admissions of trauma patients present with coagulopathy, and those that do have a coagulopathy on presentation have a 7-fold increase in their mortality. If we look historically at the management of patients in the past, a lot of history of resuscitation parallels armed conflicts. And transfusion and resuscitation practices have undergone dramatic changes over that time period. If we look back to World War I, as we learned yesterday from Dr. Harcum, that in World War I, a lot of early resuscitation was just the administration of fluids. There was the advent of blood transfusions was just starting to come out, but universally soldiers did quite poorly. In World War II, there was advancements in postoperative care. However, patients would often succumb to their injuries from infections that would be delayed in nature. During the Vietnam conflict, we started using a lot more in terms of crystalloid resuscitation. We started to see the effects of excessive crystalloid. And more recently, conflicts in Afghanistan and Iraq, we started looking at blood component resuscitation as well as whole blood resuscitation, and started to see some dramatically improved outcomes in traumatic injury. Around the same time in the late 70s, early 80s, there was a body of research that came out looking at identifying hypothermia and acidosis as the main drivers of coagulopathy, and that this was associated with early mortality in these traumatically injured patients. And it was thought at the time that coagulopathy was the result of early resuscitation efforts using crystalloid products. And around the same time, there was a cohort of data that started to emerge that identified that coagulopathy was identified early on in the patient following traumatic injuries. And this was despite any iatrogenic interventions that may have caused this. And it was found that this was significantly worse in these patients. In 2003, there were 2 studies that were published that really helped to characterize the acute traumatic coagulopathy. The first study was by Brohe, which looked at 1,000 patients that were severely injured, and they measured coagulation profiles immediately after injury. And what they found was that nearly a quarter of these patients were coagulopathic on arrival. And they found that with increased injury severity scores, that patients were more likely to be coagulopathic, and the mortality rate amongst those who did have a coagulopathy was higher than those without. McLeod, at the same time, conducted a similar study looking at 20,000 severely injured patients and found that just over a quarter of those patients were coagulopathic on arrival, and nearly 20% mortality rate amongst that cohort. And so out of this came this concept of the acute endogenous coagulopathy, where this occurs very soon after injury occurs, is unrelated to factor deficiencies, and is resistant to factor replacement. The concept of the progressive systemic coagulopathy still exists and is related to the continued blood loss and clot formation, and is related to factor depletion and requires factor replacement for correction. Concepts of damage control resuscitation have evolved to include permissive hypotension in selected patients, hemostatic resuscitation by identifying patients with coagulopathy and early intervention with blood transfusions and to avoid crystalloid resuscitation, and finally damage control surgery for arrest of hemorrhage. Massive transfusion protocols have evolved to aim the ratio of approximately whole blood with 1-to-1 ratios, and with this we have seen improvements in patient outcomes from multiple injuries. The problem with this approach, though, is that it lacks the real-time assessment of the coagulation function. If we look at the pathogenesis of trauma-induced coagulopathy, there are many factors that contribute to it. The degree of tissue injury, hemodilution, hypothermia, acidosis, systemic inflammation, which is a large research area presently, and the degree of hypotension or hypoperfusion. The two main drivers, though, of trauma-induced coagulopathy is hypoperfusion and the degree of tissue injury as a mediator of trauma-induced coagulopathy. If we look at these two aspects, hypoxia and tissue injury, what's happening here at a pathophysiologic level is endothelial dysfunction. There's activated protein C, which is decreasing the thrombin generation, increased fibrinolytic activity, and platelet dysfunction, which are all contributing to trauma-induced coagulopathy. And an area of evolving research is looking at genetics and other comorbidities of patients as drivers of this process. Now, if we look back to our experience in medical school, we've all seen the classical model of the coagulation cascade, and this is fine from an academic point of view, but it really doesn't help us at the bedside when we're trying to resuscitate a critically ill patient. The cell-based model of coagulation was published in the mid-90s, and this gives us an idea of the in vivo cell-based behavior of how hemostasis occurs, and it describes the coagulation as three overlapping stages of initiation of clot formation, the amplification, and the propagation of clot. And this is regulated by properties of the cell surfaces and their receptors. The reason why this is important is because we know that coagulopathy has a negative effect on patient outcomes, that this is a dose-dependent increase in their mortality and the blood product requirements in patients that present with coagulopathy. Our traditional evaluations of coagulopathy function is based on clinical judgment and standard laboratory tests. Standard laboratory tests include PTT, INR, platelet counts, plasma fibrinogen levels, for example. The challenge with these, though, is that they're often delayed in getting this information to us at the bedside, as well as it's not always completely helpful in defining the overall process of the coagulation function. If we look at the way clot forms, there's the initial clot formation, the platelet plug that forms in the fibrin strands, the clot begins to grow, you achieve a maximum strength of the clot, and then over time the clot breaks down and you have repair of the injured vessel. And these can be represented by our traditional measures of coagulation function as shown here. As I mentioned, These traditional measures of hemostasis, though, do not define the overall process. They just give us little pieces of the puzzle. And so what is needed is a fast, reliable way of diagnosing and characterizing trauma-induced coagulopathy. And this is done through the evaluation of in vivo behavior of blood to assess the quality and the strength of the clot, as well as the evaluation of fibrinolytic activity. And this can be done using a whole blood viscoelastic evaluation in a process known as thromboelastography. And this helps us guide coagulation therapy according to the true indication and identifying what the coagulation defect is. This here is a TEG device made by Haemonetics, which essentially works by taking a sample of blood. We drop a pin into that cup of blood and it gets rotated in an oscillatory fashion. And as the clot starts to form, you get fibrin strands that couple the pin to the cup, which is measured by a torsion wire, and this gives us an indication of what the overall coagulation function is like as the clot begins to form. This animation here shows us the initiation of the fibrin formation as well as the fibrin plug construction. And this graphical and numeric representation of the dynamics of clot formation provides us with useful information about the overall dynamics of clot formation. This is a busy slide, but it basically represents the different parameters that we can measure on a thromboelastogram to give us information about the overall clotting process. The shape of this curve dictates to us or gives us information about the dynamics of clot formation. You can see here these are some representative examples of different clotting abnormalities, and as you become more experienced with using this technique, be able to look at the plot and be able to characterize what the deficiencies are in a patient who has a clotting abnormality. Other studies have looked at incorporating TEG parameters into transfusion protocols, and so based on a specific number that is represented in a thromboelastogram, would dictate the administration of certain blood products in tailoring the resuscitation to specifically what a patient requires. So where are we at now? Well, the current debate in the literature is whether or not we stick with a protocol-based transfusion ratios or whole blood resuscitation versus point-of-care resuscitation where using the thromboelastogram we try to identify specifically what the clotting abnormalities are and target those abnormalities. In the next series of slides here, I'm going to talk specifically about the rapid evaluation, prediction of massive transfusion, and the characterization of trauma-induced coagulopathy, including hyperfibrinolysis. So the TEG allows us to rapidly collect information about the clotting function. The addition of kaolin as a reagent to the evaluation of the blood clotting allows us to speed up the reaction and get this information in a timely fashion. This is how this is useful at the bedside as a point-of-care device. This reduces the time to final results by about 10 minutes, and the parameters that are measured are the standard parameters from a TEG. So essentially it takes out the R value in the initial part of the TEG formation. This information can be useful to us at the bedside in addition to the ACT, the K values, which are available within approximately 5 minutes, and the later TEG values can be available within 15 minutes. In this study here by Cotton, they also demonstrated that the final TEG results would be available within half an hour of the original samples being collected. Also important is being able to predict the viscoelastic behavior of the blood within a timely fashion, and this study here demonstrated that the information was available within 15 minutes as well, and this improved their blood product utilization. Understanding the transfusion requirements is also a key aspect, and in this study by Moore in Denver demonstrated that with the use of early thromboelastography they could identify which patients would go on to require massive transfusions, and this is helpful in activating blood products through your hospital systems. A growing area of research right now is looking at the fibrinolytic activity of patients and understanding who's at risk of developing primary fibrinolysis and hyperfibrinolysis. And in this study by Moore's group, they identified that nearly a third of patients injured required massive transfusions had primary fibrinolysis at the time of their presentation, and that this was associated with an increased risk of death. In a further study by Cotton, hyperfibrinolysis was considered to be rare and was associated with crystalloid resuscitation. The administration or the implementation of TEG, they identified that 2% of patients had hyperfibrinolysis, according to their definition, and that patients who received at least 1 liter of crystalloid in the field had a 15% increased odds of developing hyperfibrinolysis. What they did was they went back and looked through their data sets and found that they compared the LY30, which is a TEG parameter measuring the degree of fibrinolysis, and plotted this against mortality and found that their traditional cutoff of 7.5% of hyperfibrinolysis should be reduced to 3% based on the inflection curve of mortality seen in this figure. So at present, they selectively use TXA in patients with an LY greater or equal to 3% within 3 hours of injury. And this study by Moore is even more compelling. It's looking now at the spectrum of fibrinolytic activity and dividing this into patients who have hyperfibrinolysis, physiologic fibrinolysis, and shutdown or inhibition of the fibrinolytic system. What they found in this study is that 65% of patients had shutdown fibrinolysis, nearly 20% had physiologic fibrinolytic activity, and nearly 20% had hyperfibrinolytic activity. And as you can see in this plot here, patients with hyperfibrinolytic activity were more likely to die early on in their trauma resuscitation, but those who had the shutdown fibrinolysis were more likely to die, but in a delayed fashion. These patients go on to die from multi-system organ failure. So this then asks the question, well, should we be more specific in who we target the delivery of TXA to try and prevent fibrinolytic activity to? In this study, they also looked at or identified that hyperfibrinolysis was identified early in hemorrhagic death, and that with shutdown fibrinolysis, 90% of these patients died of multi-system organ failure. So we need to be careful and cautious in who we give TXA to. So the advantages of TEG is that it allows us to characterize the clot strength. It provides a way of targeting our resuscitation of patients and to identify optimally what blood products are needed. And it allows us to rapidly characterize the coagulopathy that exists. The reduced transfusion costs associated with it have economic as well as patient benefits. So the future is here, and I think this is a growing area of ongoing research. We're seeing a paradigm shift in our resuscitation strategies away from crystalloid to blood component therapy, as well as now whole blood utilization. Techniques of surgery and damage control resuscitation have evolved, and our understanding of trauma-induced coagulopathy continues to evolve as well. And this is a growing field of exciting research. And I think TEG really offers us the opportunity to look specifically at what the patient needs and identify where or what products that the patient requires for their resuscitation. Thank you very much.